Welcome back to part 2 of our lesson 3 in this assessment of the fetal status using the cardiotachograph series. I'm Anna Nolte, and today we're going to talk about the electronic fetal monitoring as such, how to prepare the patient for doing an EFM and the machine, a little bit about the basic principles of intermittent auscultation, and then also continuous electronic fetal monitoring. When are we doing monitor the patient continuously, and when do we do it intermittently? Now, how do we prepare the patient for doing an EFM? First of all, very important is a full explanation must be given to the mother. She needs to understand everything about the CTG, the implications of the CTG, the implications of abnormalities on the CTG, etc., so that she can give informed consent. So, because she has obviously to give consent on whether she wants it or not. Now, mothers do have a choice, and they can decide that they don't want the fetal heart to be monitored with the CTG. It's just very important then that we again inform them about all the possible implications of not doing it and doing it, and then they again, as I've said, can take an informed decision and give consent or not. Then it's very important for us ourselves, who's going to connect the CTG machine to the mother, to make 100% sure why are we doing it, what are the indications, are there indications for it, and then obviously we should also record the indications. Why are we doing it? Is it the antenatal monitoring? Do we do it because the mother is some other high-risk mother, for example, with hypertension or anything like that? And then before we attach the woman, obviously we need to do a proper abdominal palpation in order to make sure where we're going to hear the fetal heart the best and the best quality, and also obviously where and how we're going to monitor the contractions. Now, the maternal position is very important when we set up a CTG or electronic fetal monitoring. And the reason why that is so important is, as we all know, that when the mother lies flat on her back, that this large uterus presses on the big vena cava inferior and the aorta, so it makes the return of blood to the heart much slower, and also eventually to the placenta, and it has an effect on the fetal heart. We also get supine hypotensive syndrome, where the mother gets hypotension because of the slow return of blood to the heart, and that might also influence the fetal heart. So very important for us to check on that. Now, the placement of the transducers, as I've said previously, is very important. We put the fetal heart rate one where we heard the fetal heart rate the best, and that's usually around where the anterior shoulder of the fetus is. So if this is, for example, this fetus is lying in this position with his back here to the maternal right side, we will hear the fetal heart rate obviously the best here, and that's where we were going to put the transducer. And the same with the uterine contractions. As we've said, we will put that on the fundus part of the uterus, because that's usually where the uterus starts contracting, and that's usually where the contractions are the strongest. And then we have said that the tightness of the belts are very important. If it's too tight, or if it's too loose, it will influence the quality of our graphs. So we have to make sure, you have to trial and error a little bit and make sure that you get the best quality of the graph before you start recording. Again, very important, like we've said in the previous part of this lesson 3, is that the maternal pulse is very, very important. It should be taken and recorded on the graph if we do it manually, or if there is a graph, then so much the better. The clock of the CTG needs to be set correctly, as I've said on the previous part. That is so important. We have to make sure that if we start this CTG at 10 o'clock today on whatever 7th of February or what. So it's because that's the times that we're also going to record this in the maternal records. So we're also supposed to record the results of the CTG in the maternal records. So if we record now at 10 o'clock that something was wrong on the CTG, but on the CTG graph it has been reflected as 12 o'clock, then there is a problem, because now there's confusion between what time was it really. All CTG traces should be labeled with the mother's name, the date, and the hospital number. And just a little bit in brief, something about a CTG trace as a record. Now, it's not a very good record, because for two reasons. It's loose paper, and we all know what happens with loose paper. It gets lost when it's not supposed to get lost. So therefore it needs to be labelled very clearly with the maternal name and the date and the hospital number, so that if it does get lost, at least we can get it back again. The other thing is CTG traces, and also again depending on the brand and the brand name of the paper, some of the traces fades very quickly. So it is very important that everything that you get on the CTG tracing should also be recorded in the maternal records from time to time. You should record the baseline, the variability, whether there are decelerations, etc., so that one can see what's going on. And then we will get to it later again. Everything that's been done to the mother during labor, like for example membrane's been ruptured, or augmentation of labor started with oxytocin or anything like that, should be also put on the label, on the CTG, as well as obviously the maternal records. Then we use the initial 5 minutes of our CTG graph to just make sure that it's a good quality graph. And if it's a good quality, obviously we can use those 5 minutes. But again, as I've said previously also, it's so important that we have a good tracing of both the fetal heart rate as well as the contractions. And as I have said previously, I know that sometimes during labor specifically, mothers are restless, and that makes it then very difficult to get all these things to really get a good quality graph, CTG graph, cardiotachograph graph, the cardiac part as well as the tachograph part. But we need to get as much as possible of that. And then also, just while I'm preaching on quality and 5 minutes, it's also very important that we should be very careful on how long we are doing our CTG graphs. And we will get to that again when we do the interpretation of the CTG graphs. But under no circumstances ever stop a CTG graph the moment that there's something abnormal on it. So if there's, for example, a deceleration, don't stop the CTG, don't stop the graph. Let it run for a little bit longer, so that we can see what's happening with these decelerations. Is it getting worse or whatever? And we will see that's also very important when we get to variability and the sleeping periods of the fetus. So the time that we take our CTG is also very important. Now, aspects that's important during the recording, as I've said, any intrapartum events that may affect the fetal heart should be recorded, like a pain medication, for example, syntocinin started, a membrane's been ruptured, or etc. The characteristics of the trace should be recorded in the maternal notes. As I've said, every single thing that's on your graph should be on the maternal notes as well. And it also helps to determine later on whether you could have read and interpret the trace correctly, because sometimes midwives say there's nothing wrong with it, or there's nothing being recorded, and then it's not clear whether, but the patient was on continuous CTG, so the fetal heart rate was continuously measured all the time. But now it's not clear whether the midwife knew how to interpret it. So that's also one of the reasons why it should be very important to record what your findings were about the CTG. Then the moment that we get an abnormal CTG pattern, there's something like bradycardia or like a deceleration or variability gets lost, etc. It's very important to immediately check on the maternal position. Like we've said, she should be in a 45-degree upright kind of position to prevent supine hypotension. Now, it's important to determine whether this abnormal fetal heart pattern is due to the hypotension or not. And then every time the doctor sees the CTG, he must also sign on the CTG to say that he has seen it and what he has interpreted on it, that it's normal or that it's abnormal or whatever. And then, as I've said, my long sermon on the length of the assessment is very important. Normally during labor, it's a good idea to do it for at least 30 minutes. During the antepartum period, 10 to 15 minutes is usually good enough if we get a good reactive pattern. Obviously, again, if the pattern is not reactive, one might need to do it for a longer period to make 100% sure what's going on. Just a few things on intermittent auscultation. As I've said, we can do it in two ways. We can do it with a handheld Doppler, like you see here. It works on the same principles as the CTG machine. It picks up the fetal cardiac movements and with ultrasound transmission transmits it into the machine. On a little video, on a little window, you can see the heart rate of the fetal heart, and that's basically the only thing that we can really see. We can see it because it's a digital window, we can see a little bit that the fetal heart rate varies, and we can hear when it's going slower or not, and I'll get to that just now. That's the dop tone, and then what's good about this is that the mother can hear the fetal heart as well. Or we can do it with a fetal stethoscope that I think not many midwives still know about and how to use. But that's also, and as I've said previously, there's lots of evidence that a fetal heart can be recorded quite accurately with the fetoscope as well. We can determine with both the dop tone as well as the fetoscope, we can determine the baseline, we can determine the rate, fetal heart rate, and we can determine whether there are accelerations and decelerations. We can clearly hear when you listen long enough to the fetal heart, both with the dop tone as well as with the fetoscope, when the fetal heart rate goes down and when it speeds up again. We can't determine the variability accurately enough. With a fetoscope, you can't do it at all. On a dop tone, I've said that you can see a little bit that the fetal heart rate varies on the digital window, but that's not accurate enough to determine the baseline variability. That can only be done accurately with a CTG machine. So we can determine, and the moment that we pick up any abnormalities and decelerations, accelerations we're happy with, if we pick up any decelerations on a dop tone or on a fetoscope, it's obvious that we have to do immediate start CTG so that we can diagnose the decelerations and make 100% sure what they are. Now, the fetal heart should be monitored for 1 minute before, during, and after a contraction, and in the active stage of labor every 30 minutes. So, and this is very important so that it enables us to pick up deceleration specifically after contraction. And during labor, we do it with after every second contraction. We listen to the fetal heart rate before, during, and after contraction. And again, I know that it's very difficult, especially because the contractions get stronger, the mothers get more restless, they don't want to lie still during a contraction, etc. But with the dop tone, it's fairly easy. With the fetoscope, it's difficult because the mother really has to lie still, but she can move a little bit around with the dop tone. So it's very important to do this after a contraction, during and after a contraction, because otherwise we might miss the decelerations, which is very important for us. Now we can, can we diagnose hypoxia with intermittent auscultation? I've said yes in the very beginning. Evidence has shown that we can do it, is as in a very accurate way. So we can do it. We can determine the presence of deceleration, specifically if they continue after contractions. We can determine whether there's an increase in the baseline. So we can determine tachycardia, we can determine bradycardia, and these, as I've said, are all very important things for us to determine hypoxia. And then after we've done that, is to immediately start to monitor the fetal heart with a CTG. And again, very important to monitor the maternal pulse. Just a few words on when do we continuous electric fetal monitoring or CTG and when do we do it intermittently. We can do it intermittently, like in every 30 minutes. We can do a short tracing of 15 minutes if everything is normal, or we can do it hourly for about 30 minutes, depending on what's going on. As we've said in lesson 1, we normally don't do CTGs in low-risk women. It might be a good idea to do a CTG when we admit the patient just as a baseline to make 100% sure that everything is normal, and then afterwards continue with intermittent auscultation. These will be all the indications to do continuous electronic fetal monitoring. Previous seizure, meconium stained liquor, poor progress in labor, suspected intrauterine growth impairment, suspected fetal distress, oxytocin and infusions. This is a must. The moment that you put up oxytocin and infusion, whether it's for augmentation or whether it's for induction of labor, it's so important because it might cause hypertonic contractions, which definitely has an influence on the fetal heart. Prolonged rupture because of the possibility of infection, chorioamnionitis. In the case of preeclampsia, antepartum hemorrhage, multiple pregnancy, and epidural analgesia. All these are indications for continuous CTG. And that brings us to the end of lesson 3, part 2, and now it's quiz time. So I hope that you have learned a little bit about how to prepare for a CTG and the general important principles of a CTG. See you in lesson 4.